Okay, look, it's 5 past. So maybe we can transition into the seminar. So I can see we've got a bunch of attendees there now. Welcome everyone to the Cecil Gibb seminar series. We're now in week 6, I believe, if I'm tracking correctly. Just a few housekeeping rules before we start. So just a reminder to everyone, we record these seminars. We do cut them, Brett, so we trim the start in the end, and those will then be available on our YouTube playlist if others are interested in revisiting this. Upon entry to the webinar, you've all been muted, and we ask that you stay muted throughout the duration of the webinar. You will, as you'll all know, have the opportunity to ask questions at the end, and we really welcome that. It would be fantastic. So you can add questions in the Q&A box, and you can also throw your hand up at the end, and we'll make sure we get around to getting your questions is the wording I was looking for. Okay, now I'll hand over to Connell to introduce our speaker for the week.
Great, thanks, Erin. I feel privileged to welcome today Dr. Brett Scholz, who's a research fellow at the ANU Medical School, who focuses much of his research on critical health psychology. He's also an adjunct senior lecturer at the University of Adelaide and an adjunct associate professor at the University of Canberra. Brett's research focuses on ways in which health services can be more equitable, challenge power norms, and be consumer-led. Unfortunately, consumers are often left out of the decision-making process in all areas of health services. And so today, Brett will talk to us about meaningful engagement of consumers at all levels of decision-making throughout our health systems. And I might also hand over to Brett to give us a bit more about his journey into psychological research.
Thank you, Erin and Connell, and Yuma, everybody. Before I begin, I'd like to acknowledge that I'm giving this talk from the land traditionally owned by the Ngunnawal people. And I think it's something I've been reflecting a lot, particularly in lockdown, and maybe because it's sort of the longest that I've ever spent, you know, in Canberra for any period of time, about the importance of connection to country. And I guess I've also felt that a little bit being disconnected from my hometown and family and friends back at home. So I think it's really important to acknowledge and pay respects to the elders of the Ngunnawal people, past and present, and I'd also like to extend those respects to any Indigenous peoples who are with us today. As Connell very eloquently introduced me, I'm going to be talking about consumer leadership in health systems. And I have examples later on in this talk about consumer leadership in health policy, in health practice, in health education, and health research. But essentially, I believe that it's our duty as health professionals to be supporting consumer leadership in anything that we do in the health system. A lot of the work that I've done relates to mental health specifically, and so a lot of the examples that I'll give are about mental health. But that's not to say that these principles couldn't be applied to consumer leadership across any kind of health domain. And in fact, I would really like to see that happen. A lot of the consumer-led focus in mental health has come from a very passionate and marginalized and vocal consumer movement of people who have lived experience of mental ill health and the associated stigma and all of the issues that come along with it. And so that's why, in some ways, in mental health, we're ahead of the game, and we're doing a good job in some ways of being more consumer-led. Not to say that we don't still have a long way to go, but it also means that other areas of the health system might not be at that same level. Anyway, it strikes me that the first thing I should talk a little bit about when I'm discussing consumer leadership in health systems is actually, well, what is consumer leadership? I have a PhD student who's dedicated her entire PhD to seeking to answer that question about what is consumer leadership. So I'm not going to pretend that I can answer that question in the next little short period of time. You can see that consumer leadership has been defined as being difficult to define. So I thought what I'd do instead of trying to define consumer leadership is talk a little bit about the history of consumer movements, where we've kind of come from in terms of consumer leadership in the health sector and where I think we should be going. So as I've kind of alluded to, there is a strong advocacy background to consumer leadership. So, and the consumer movement is tied to other social movements, you know, and I have images here from the 1960s of, you know, people protesting the Vietnam War, people protesting for gay rights, and indeed around that same time, so in the 1960s and 1970s, the consumer movement sort of emerged from this social setting at the time, which was pushing for equality and fairness. And as I mentioned before, a lot of it came from the mental health space, because people who had a lived experience of mental ill health had suffered things like seclusion, restraint, you know, other forms of violence against them perpetrated by the health system. And so, although it, I guess the consumer movement, although it emerged in the 1960s and 1970s, it has had a relatively slow, compared to some of the other movements, way of filtering through to the mainstream. Now's probably a good time. I probably should have mentioned this before, but I'm actually a psychologist by background. I consider myself very multidisciplinary. I've worked in a nursing and midwifery research centre. I currently work in a medical school. And it's something that I reflect on often, that as psychologists, we are considered by others, and also, I guess, consider ourselves to be the experts of mental health. And alongside some of the other health disciplines, of course, as well, like mental health nursing, psychiatry, occupational therapy, social work. So it's not that, you know, we own the mental health space alone, but it does strike me that so much of what we do and have done historically in the mental health space has been doing things to people rather than doing things, or even doing things for people rather than doing things with people. And that's kind of going to be a recurring theme throughout what I'll talk about today. Consumer leadership is, as I said before, very difficult to define. And partly that's because it's done in lots of different ways, and in different settings is done in lots of different ways. But here there's a link at the bottom of this slide to a study that one of my honours students published a couple of years ago. And she found that consumer leadership is typically has these 4 elements in it. So it typically involves application of lived experience. It typically involves a desire to influence service design or delivery. And it typically involves collaborative practices or connections with others, and in particular, connections with people with lived experience. And it also typically involves promoting a culture of inclusion and support, particularly for other consumers. A really important point to make as well is that consumer leadership doesn't necessarily require a defined lived experience role. So, for example, you know, there are health commissioners who are in that position because they have lived experience. So, for example, when I think about New South Wales, they have a mental health commissioner specifically in that role because of their lived experience. And that's something New South Wales has done for some time. Other jurisdictions have done in similar ways. And I think that's, in some ways, that's a really obvious example of a way in which there is somebody with lived experience using that lived experience in their formal role at a very senior level in the mental health sector. But this study also found that you didn't need to have a formal role. You didn't need to be, you know, a mental health commissioner to be a consumer leader. Rather, to be a consumer leader, you needed to just be applying your lived experience to want to influence service design or delivery, engaging in collective practices, and promoting a culture of inclusion. And I think, you know, as I started to allude to before, consumer leadership can actually be enacted in lots of different areas. Health policy is, you know, what I think of as being one of the higher levels of consumer leadership. And when I think about, for example, you know, a mental health commissioner coming from that consumer perspective, that's a really good example of high level health policy. But there's also consumer leadership in health services. I'd love to see more in education and more in research. I have examples that I'll get to a little bit later on of each of those domains. But I just want to be clear from the outset that, you know, when I'm talking about consumer leadership, I'm not just thinking about the policy level. I'm also thinking about services, education, and research, and probably beyond as well. Okay, so you might ask why we should care about consumer leadership. I think there are lots of reasons. I'm just going to take a sip of my tea and then talk about them. So the first reason for me is that the lived experience perspective is kind of a missing piece in a lot of what we do in health. So, you know, often when we talk about multidisciplinary teams, or when we talk about probably something that we've all done in this Zoom room, when we talk about conducting multidisciplinary research, typically we think about engaging with doctors, nurses, you know, maybe occupational therapists or some other people across allied health. And it's not yet the norm that we think that we should be engaging with consumers as equal partners in the same way that we do think of colleagues from other you know, disciplines. And so for me, that lived experience is often the missing piece, and a really important missing piece as well, because consumers are the people who have actually experienced the services that we're setting up for them, the education that we're providing to, you know, train people who will look after them, the research that we're doing, you know, in their best interest ostensibly. So if we want to be providing better quality care and to alleviate concerns about health inadequacies that arise from, you know, excluding consumers, consumer leadership to me is one of the most important things that we can be doing. So they're that missing puzzle piece, but there's other benefits as well. The next benefit that I'll talk about, which I don't necessarily think is, you know, the most important benefit by any means, but one of the other benefits to having a consumer-led health sector is that we can provide more cost-effective care. So health organisations can provide better care and reduce costs if we base our decisions on knowledge and experience of what consumers, you know, face in our health systems. Consumers can also tell us what services are irrelevant or what doesn't fit with their needs or interests. And so we can reform our health system based on consumers' needs so that we're providing better value for money care. And another personal one for me is that it improves social justice. If we have a system that is led by consumers, then we're not excluding the people who are most impacted. And it's empowering to know that consumers have a say over what we do in the health system. Okay, so with all of those barriers that I've just mentioned, you might wonder, well, why aren't we just, you know, why don't we have a consumer-led health sector? Why don't we have, you know, a school of consumer leadership within every university across the country and the world? Well, there are a few reasons. The first big one for me is stigma. So obviously, I think we're probably all aware that there is a lot of social stigma against consumers. A lot of that actually comes from us as well as health professionals. You know, it's a lot of the research that I do is co-authored by consumers, and that's a really important part of my work. It's something that I write up in all of my method sections about the perspectives that consumers bring to the research. And I still get sometimes, you know, peer review from other health professionals who are peer reviewing submissions to journals, asking, you know, why would we collaborate with consumers? Did we not care about their mental health? Implying that we were somehow, you know, exposing our consumer collaborators to extra risks that they shouldn't have, or something like that. And it just strikes me that this stigma is so pervasive that we assume that consumers, because they're consumers, lack capacity to engage in all the things that we do as health professionals, even though they actually live these experiences every day of their lives. So, I mean, that's just one example of stigma. There's lots of others, and I'm sure that you probably all have examples of stigma that you've seen against consumers in your own work as well. But what I think, you know, strikes me, and what I don't think we talk about enough, is that there's a lot of stigma that we hold as health professionals, as well as just the stigma that's out there in society more broadly. There's other barriers as well. So a couple that I'll speak about are, first of all, issues of power. And you can sort of see I've chosen this slide to represent, you know, people grappling for power. There's references that I can provide if you're interested in hearing about any of this, but we worked on a paper a couple of years ago called something like Breaking Through the Glass Ceiling. And we had consumers working in the mental health system telling us that it felt like a glass ceiling, that they had to work twice as hard in organizations to be seen as equals to the psychologists or psychiatrists or other mental health professionals. They were often allowed peer support roles, relatively low-level roles in terms of power, but rarely progressed through the system to be, you know, directors or be in agenda-setting roles. So one barrier is issues of power that we're kind of all aware of in the health system anyway. And the last barrier that I wanted to talk about is that there are operational problems. So there are some consumers in leadership positions who experience limited inclusion because of a lack of clarity about their roles and responsibilities. I remember when I first started doing some of this work in about 2015, I'd never really heard of a consumer representative, you know, as a role within a health organization, but most health organizations will have consumer representatives that sit on their committees or that contribute to various projects. And often there's, not only do the position descriptions for those consumer representative positions lack clarity, often the consumers who fill those positions are also a little bit unsure about who they're meant to be representing, and the people who are employing them or engaging them also don't necessarily have that clarity. We also privilege medical knowledge over consumers' experiences. So working with consumers can present a very new paradigm for many health professionals and administrators. So those are some of the barriers. I mean, there's more, but that kind of gives an overview of why we don't have a consumer-led health sector currently. For the next 4 slides, I'm just going to give some examples of consumer leadership in policy, then services, then education and research. The examples I'm going to draw on are just me kind of talking about some of my own observations and experiences. So they're by no means, you know, the best examples or the most representative examples, but I thought it would be useful to kind of chat about my experience in consumer leadership across these domains so that you can start to think about how you might engage with consumers in whatever you're doing, whether that be in policy, whether it be in service provision, education, or research. Okay, so I'll talk a little bit about health policy first. And I wanted to actually talk about a very personal experience and a very recent relevant experience of engaging with consumer leadership in the COVID-19 response in 2020 last year. So towards the start of the pandemic, obviously the COVID response happened very quickly. Consumer engagement was often one of the first things to be forgotten or deprioritized in the COVID-19 response. There are some great examples, and I'm about to give an example in a moment, where there was good consumer engagement in the COVID-19 response. But from what I've observed and heard from colleagues anecdotally, there are by far more examples of consumers being left out of decisions about responding to COVID. Here in the ACT, though, we actually had a really good experience with engaging consumers to build policy about COVID. So in about March or April, a triage system was developed initially, that was going to be implemented if Canberra ever got to the position of needing to surge or super surge in ICU capacity. And the preliminary triage system that was built was done without consumers. It was done by mostly clinicians. And there was an opportunity for some consumers to provide feedback, but it was very rapid, mainly because we just didn't know if COVID was going to be a big issue in 2 days or if it was going to be an issue in months. By about June of 2020, we realized that we had a little bit more time here in Canberra to more meaningfully engage consumers. And so the Clinical Health Emergency Coordination Centre actually led a process whereby 26, I think, different consumer, carer and community organisations collaborated to develop the principles that should underlie the triage for COVID in the ICU in the ACT. And so that took a period of a few months, and I think by about September or October of last year, that policy was put in place. It still hasn't had to be used, and touch wood, we never have to use that here, or we never find ourselves in the ACT in a position where we are at surge or super surge capacity. But what really struck me about this policy was that basically our triage system here in the ACT is based solely on human rights. The principles underpinning our triage process, unlike any other jurisdiction in Australia, is that there can be no discrimination, and that applies across a range of intersectional identities. So whereas some other jurisdictions do discriminate in their COVID triage based on things like age or based on things like comorbidities, here in the ACT, we actually don't. And for me, that was a huge success of a consumer-led policy development process. All right, let's move on from policy and talk about some examples of consumer leadership in service. Oh yes, I was just, you might have seen I was looking a little bit blank. I was trying to remember why I had this image as the slide, but it has come back to me. So yeah, this is a very, very specific example, but again comes from the ACT. So here in the neonatal intensive care unit, so the NICU here in the ACT, there was probably a bit more than half a decade ago now, a new collaboratively designed ward for the NICU. And consumers, and in this case, when I talk about consumers, I'm mostly talking about parents who were involved in, who had been in the NICU, obviously with their baby, were involved in co-designing some of the features that the new NICU should have. And one thing that's really simple, but really quite profound, is that, a number of the parents who had spent time in the NICU said that there were no reading lights near the beds. And so that meant, they're sitting there probably for up to 24 hours a day, close to 24 hours a day, next to their babies, and something like a reading light for lots of them was seen as something that would just be so invaluable, would be a really easy thing to implement, and would bring about change quite quickly and just make consumers more comfortable. So that's just one example of ways in which consumers' experiential expertise can improve our health service offerings. There's actually billions more. But for me, the reason that I wanted to speak about that one is because I think it's just an example of something that could be really easily implemented. But it's also an example of something that we, as health professionals, don't necessarily think of. You know, we're not sitting next to the NICU crib for 24 hours a day. So we don't realize something like a reading light would make the world of a difference. Okay, so I've given an example now of policy and an example of service. I'd like to talk a bit about consumer leadership in education. And this is obviously something that, you know, probably most of the people in this room are interested in or thinking about. So there are a handful of examples that I've seen in psychology of people co-creating curricula and co-delivering curricula together with consumers. And when I see it, I think it's absolutely brilliant. So one example comes from Massey University in New Zealand. So their clinical psychology program actually has a consumer, or in New Zealand, they don't use the term consumer, they use the term service user academic. So Massey University has a service user academic who teaches, who co-teaches, has co-developed the curricula and co-delivers the curricula to students from a lived experience perspective. That's probably one of the best examples I've seen in psychology. And I would say we're probably lagging behind some other disciplines, because I've seen a lot more examples in mental health nursing. And I've sat in on a tutorial that was developed by and delivered by a consumer researcher a consumer academic in mental health nursing. And I found it completely profound. The students found that session one of the most interesting sessions of their entire course. I'm not going to say of their entire degree, but certainly of that subject, because hearing from people who we actually want to be, you know, doing a better job of serving is quite a profound experience. You know, it strikes me that, you know, I remember when I did my psychology undergrad, I don't think I even had any exposure to consumers whatsoever. And by the time I started teaching Psychology 101 in 2013, we didn't really have, we still didn't give students very much exposure to consumers. I think we had a 1-hour session with MEACT, which is Mental Illness Education ACT, which is a group which is people coming around giving talks, usually about their experiences with mental ill health. But it was never embedded in the curricula. It was never, the people delivering that curricula weren't academics on staff within the university. And I think that's where we do need to be heading. If there are people who are interested in how you might do that and you'd love to chat more, then do send me a line, because I'm happy to talk a lot about that. I could talk for hours and hours about that. But I guess, you know, keeping in mind that it is starting to happen more and more in other disciplines. I did mention mental health nursing, and a couple of years ago at the University of Canberra, along with about 5 other universities across Europe, we did get a significant Erasmus Plus funding grant to embed consumer academics in those universities. And although in Australia, the university didn't continue to employ the consumer academic, the 5 universities in Europe still have full-time consumer academics on staff after that program finished. And this is the way that I think education will be going. So I would love to see us getting on that curve and actually developing and delivering curricula together with consumers. All right, the last domain that I want to chat about is consumer leadership in research. And I've put up here a slide about co-production. there is other ways of doing consumer-led research besides co-production, but I thought it would be good to just spend a few minutes chatting about co-production, because I think it's becoming a bit of a buzzword. Some people aren't necessarily sure exactly what it is. I was recently reviewing NHMRC ideas grants for this year's round, and I saw lots of people talking about co-design and co-production. And then I looked at the researcher list and there was no consumer present. And I was wondering, how are you actually going to co-design or co-produce if you haven't shown, or you haven't made it clear in your application how you're actually going to do that, or who's responsible for that, or what that will look like. Anyway, my absolute go-to for anything about co-production is this resource that I've linked you to here. It is in itself co-produced. So Kath Roper and Flick Gray are two brilliant consumer academics, consumer activists in Victoria, and so have a wealth of experience of examples of co-production they've been involved in that's really gone quite poorly, and examples of when it's gone well. And I think that really shines through in that resource. So I would be downloading that. It's there's a free download through the University of Melbourne website, and reading it from head to toe. But essentially, when we're talking about co-production with consumers, we're talking about making sure that we're engaging consumers from the beginning of a project through every single stage. So that means that consumers should be having agenda setting and decision-making power over how a research project unfolds. I see examples of papers that are written that say, oh, we had these co-researchers who were consumers who came in and did the interviews. And then they never talk about the consumers again. And it's not clear if, the consumers were involved in the epistemic processes, if consumers were co-authors or not, or if they just came in, did the interviews and then left. So I'd love to see a lot more clarity and explicit reporting about, co-production with consumers. Anyway, as I say, in terms of education, it's something that I think a lot about. And if you are interested in working towards principles of co-production in your research, have a look at that resource, but I'm also happy to chat at any stage. I'd like to close with, I think it might actually be 4 things, not 5 things, but maybe I did end up putting in 4. Anyway, we'll see as we go through the next slides. But just a few things that you can do right now to support consumer leadership, regardless of whether you're working in mental health, whether you're a researcher, whether you're a clinician, whether you hold multiple identities and roles across your position. But the first thing that you can do is to be reading and citing consumer-led or co-produced work. So these days, whenever I'm starting a new project, the first thing I'll do is I type into Google Scholar, the topic. I'll be adding to my search terms, consumer co-researcher, consumer-led, co-produced, just to see if there is any work out there. In some fields, there's none, sadly. But currently I'm just starting a new project in youth suicide prevention. And the first thing I did was to have a bit of a Google. Is there any consumer-led or co-produced work about youth suicide prevention? And those are the first things that I've saved in my EndNote that I intend to cite to show the value and importance of consumer-led work. The next thing that you can do right now, and it sounds quite trite, but listen. So whatever field you're working in, if you're working in mental health, it would be great for you to go and chat to ACT Mental Health Consumer Network and listen to what kind of research they would find valuable for you. Some of my work in end-of-life care, for example, I went to chat to there's a national registry of consumers of end-of-life care, and I went and just had a chat and genuinely listened rather than, presuming that I would know best as researcher. And I think, it sounds kind of obvious, but I think it's a step that often isn't done. And I think even if it is done, sometimes consumer groups don't necessarily feel listened to. And I think it's really important to demonstrate, if you want to be genuine about supporting consumer-led work, or if you do want to be collaborating with consumers, then demonstrating genuinely listening, I think, is really important. The next thing that I think is really good that you could be doing right now is to build collaboration into your projects and budgets. So I've just included this image here from a recent successful funding opportunity where I built into the system consumer, so a lived experience research officer, so somebody coming from that consumer perspective into the budget, so that we are employing and able to have someone who is embedded in that team coming from a lived experience perspective, noting that we actually also have academics on that team who will be coming from a lived experience. But I think, you know, we can often forget that it's really important to acknowledge that lived experience should be valued just as much as other experiences and skills. And so valuing somebody as a research assistant because of their lived experience, I think sends a really good message. And the final thing that I think that you can do right now to support consumer leadership is to make space for consumers. So similar, this might look different in I don't know, a range of ways, but let's say, for example, you're invited to a panel because of your expertise in something related to mental health. You know, you could ask, are there people on that panel coming from a lived experience perspective? Do we have at least, you know, a couple of consumers on there? Is it not just going to be a panel of psychiatrists and one psychologist, for example? Other ways that you could make space might be, I'm just trying to think of examples of ways in which I've made space. Well, even yeah, just a recent research project that I've just begun, that one I was talking about before. When I was thinking about who I'd like to collaborate on that research project with, I was looking for people with lived experience to be my collaborators. And that was how I try to make space. But it might be different in whatever circumstance you're in, but I think that you get my point, that, you know, we are as health professionals, as psychologists, seen as experts, and we are. I'm not saying that we don't have that expertise, but I think we can use that privilege and that power that we have to try and make space for others and try to ensure that we are at least having consumers as equal partners in whatever we do. All right, that's actually all that I have to talk about. I mean, I have lots of other things I could say. This is an area I'm very passionate about, and I'm always happy for anyone to make time to chat with me about this at any point. But I might leave it there for now and yeah, see if there's any questions or comments or anything that you'd like to share.
Great. Thanks again, Brett, for talking to us today and leading us through and kind of all those steps in how we can integrate consumer-led research into our own work. In addition to, it's fascinating to hear about actually some pushback from reviewers regarding integrate consumers into our work. It's actually something that I wouldn't have even considered. What we'd like to do is open up the floor. It looks like there's Julia, who might hand over to you, if that's okay.
Thank you, and thank you very much for a very interesting presentation. I just thought in the spirit maybe of making space and just for people to be aware, I'm not sure if people are aware, we do actually have a consumer-led research group in the Research School of Psychology. An Associate Professor, Michelle Banfield, is a consumer academic who has led that and developed that through competitive research grants. Michelle does a lot of really interesting work in translational work with mental health, and has also held positions at sort of national levels, including for the APS in terms of policy and advice and that sort of thing too. So I think yeah, if you're thinking about collaboration and sort of other advice, Michelle is also a really great resource, I think. So I just wanted to mention that. Thank you.
Thanks, Julia. If you'll,
Kristen's there.
Kristen?
Connor? Yep.
Fantastic.
Hi, Brett. How you going? Oh,
I'm good, Kristen. How are you?
I'm good. It was an awesome talk. I wanted to say thank you for sharing your experience and recommendations around consumer leadership. And one of the things I was considering as you were talking that really struck me was around the role statements for the consumer sort of advocates or representatives or leaders within health settings. And having had some experience in a health service where there was a consumer representative, one of the interesting I think dilemmas that came up for health professionals was around things like confidentiality for the clients that you're working with. And so I was just curious about whether there's any progress in that space or how you think we could strengthen those role statements and think through those dilemmas, including consumers in that process as well.
Yeah, thank you, Kristen. Really good and relevant point. I don't know that there's necessarily been many improvements or enhancements to that's still definitely a contentious issue. Just a couple of years ago, I was doing a study on how people understand consumer representation and what they actually mean when they talk about representatives or those kinds of concerns. And we found that both some of the consumer representatives who were part of that study and also their directors still lacked clarity on what they were even meant to be representing. So, for example, there's an ongoing kind of discussion and debate around, is a consumer representative representing their own experiences? Are they meant to represent consumer experiences more broadly? If we do, then they need to be resourced to be able to do that. We can't just assume that. Similarly, I guess when I'm on a committee as a psychologist, I'm not representing all of my psychologists, and sometimes we have these debates around consumers that we wouldn't necessarily have around more established roles. So I think that's really interesting. Sorry, this is a really long-winded way of getting to my point, which is I don't think it's necessarily gotten better. I do think that we need more clarity, and I've written a little bit about that. I don't necessarily know that it's improving anytime. So yeah. So it's definitely something that's an ongoing concern.
Thank you. That's super helpful. And I wonder whether having consumers inform those role statements would make a whole lot of sense as well.
Absolutely. Yeah. I mean, and it's funny that of course, that is an absolute sensible answer, but it's something that I don't see happening enough.
Yeah. Awesome. Thank you, Brad. It was really great. And I hope you're doing well.
Thank you.
Great, thanks, Kristen. Is there any other questions?
I have a quick, I can jump in, Connor, in case people are still pondering. Brett, that was really, really fascinating. You made me think about, we're doing a little bit of work with virtual courts and how that's been run, looking at Australia and different places around the world. And when I think about that, I think about the consumer being sort of at a number of different levels. You've got the judge and then different lawyers, you've got the victim and defendants. Have you worked ever in that kind of space before, or with several levels of consumer? What are your reflections on that?
Yeah, thank you. Really good question. So no, I haven't worked in that kind of space. The only thing that came to mind that is semi-related, but probably a bit of a diversion from what you're talking about, is there is a little bit of work that's come from Victoria, I think, about forensic mental health and engagement with consumers. So people who are who have a mental health condition and are also currently living within the justice system. And so thinking of those people as consumers and how we can collaborate with them, given multiple layers of, marginalization and those kinds of things. That's a slight probably diversion from your question, which I think is that, I guess for each of us and the different areas that we're working in, who we consider a consumer and what that might mean might differ a lot across contexts. I guess a lot of my work's informed by consumer leadership in the sense of the mental health consumer movement. And so therefore, it's often looking at how we can facilitate empowerment of disempowered or marginalized people. And so I guess I would see, people like judges or people who hold positions of power as not necessarily fitting into the frameworks that I'm using. Having said that though, I think that we should be doing more co-produced research, whatever we're doing. And I think that level of actually engaging, say, for example, with judges or people who might not necessarily be disempowered or marginalized, I think we should be, as researchers, involving the people that our research affects in the epistemic principles and processes of our research anyway. So if you're doing research with somebody like a judge, I actually would love to see those collaborators come on and inform the research questions that you ask, or the kinds of analysis that you might do, or the theory that you use to explore your analysis. So I think that can certainly be applied across the board. And I guess it just to kind of finish off that point, I think whatever we're doing, whether it be with disempowered groups or not, if we're going in there and collaboratively producing knowledge, then I think we're doing a better job than we necessarily have been traditionally in psychology and the other health professions.
Thanks, Brett. It's really, really fascinating area, and I think you've given us all a lot to think about. Thank you very much.
Thank you. People may already be thinking about our upcoming town hall.
That might be the case. Well then, unless Kristen has a second question, I've got a feeling that she just enjoys having her hand up. Oh, there we go. I guess a question that I had on my mind, just to, to finish up today, was when you do reach out to consumer groups, how engaged and willing are these kind of groups to participate in research? Is there any way about kind of building those alliances that you would suggest?
Yeah, great question. I'm glad you brought that up. It really varies, but I think there are lots of consumer groups that are used to people kind of coming in, colonizing the space and then going away. And I think the best co-produced research I've ever done has been where there is an ongoing relationship, or it's not necessarily the first time I've worked with a group's been the best, and those relationships do grow. So I do think there is an investment of time and effort and genuine relationship building that I think is important, because people do want to see that you're in there, you're not just coming in there to get access to participants and then go. It probably varies from person to person. One of the things that I have found really tricky in the past year is you can't just drive to somewhere and have a chat face to face. The fact that we're in lockdown and we're having to have these kinds of trying to make connections over Zoom, it's difficult, and so I don't necessarily have an answer for how to fix that up, but I do think it just requires some thought. And if you do know any sort of relationship brokers that can help give you an in to the group that you want to collaborate with, then that can be a huge help.
Great, thanks for that. I think that's a really important point in terms of the consumer-led, not just kind of consulting them as kind of a once-off consumer group, but instead having them involved in planning, treatment theory, and also seeing the benefits of that research integrated back into their lives.
Yeah, absolutely. Thank you.
And thanks so much for today. It was fantastic to hear you talk. And if there's no more questions, we might end that there. I hope everyone enjoys the rest of their day.